Okay, just a short talk about the oxygen cascade. So what does that relate to? Well, the oxygen cascade relates to the drop of the oxygen pressure as we go from room air step by step eventually to the mitochondrion inside our cells. And mitochondrion, if you remember, is a organelle. It's a little internal organ inside the cell, and its main function is to produce energy, and it does that hopefully aerobically, and it burns then glucose with oxygen. And therefore we're now going to have a look at how oxygen gets from room air into the mitochondrion. So there's one really interesting aspect, at least for me it's interesting, and when I first encountered it, and that is that a gas can remain a gas but at the same time be dissolved in a fluid. So for example, we have a fizzy drink, a Coca-Cola, or if you're a bit more fancy, like I like to do on the weekend, open a bottle of champagne. As soon as you take the cork or the lid of the bottle, you see air bubbles come out of the liquid and they reach for the surface. So that idea is that the pressure above the liquid is reduced by opening the bottle, and hence the solubility of the gas in the liquid has changed. So a good example of that is the bends, where people go deep sea diving. When you're very, very deeply in the ocean, the pressure of the water is enormous and your body can dissolve way more oxygen than at ground level. And if you would go back to ground level out of the ocean above water too quickly, then the solubility of oxygen decreases too quickly and you get air bubbles in your blood, and that causes an embolism, and it's called the bends. Alright, so now we've just looked at that practical example. Let's see how this works. So in room air we have a pressure of about 1 atmosphere, which translates in 760 millimeters of mercury. Now room air for 21% is oxygen. That means that the partial pressure of oxygen in the air is 0.21 times 760, which is 159.6, and that is approximately 160 millimeters of mercury. So now we start inhaling that air, go through the nose and mouth, our throat, which is called the larynx, then through the voice box, which is called the larynx, and goes into the windpipe. And once air has reached the windpipe, air with oxygen, then we find there's humidification happening of that air, and oxygen is no longer 21%, meaning that it has dropped to 150. Then if we further go down to the alveoli via the main bronchus and the bronchioles, we end up in alveoli, alveolar sacs, and the pressure now has dropped to 105 because of the admixture of other gases. And so that 105 is the driving gradient pressure to press air from a higher pressure to a lower pressure. Your venous blood is low in oxygen, and therefore your blood starts oxygenizing. And we call that gas pressure in your arterial blood PaO2. Now, a lot of you are familiar with the pulse oximetry. And with pulse oximetry, you measure the oxygen saturation of hemoglobin. So your body wants more oxygen than it can dissolve in blood, so therefore it has a carrier protein with an iron atom inside of it, and that's called hemoglobin. It's found in red blood cells. So we're going to later look at the relationship between the arterial oxygen pressure and the saturation of hemoglobin, but it's not the same, and you must remember that it is the arterial oxygen pressure that gets oxygen to the cells, and the only way to find out what that is through taking a blood sample and analyzing it in the blood gas machine. Alright, so we go to 105, and then the arterial oxygen levels will be about 80 to 97. So it tends to drop as we get older. There's a little formula, I think it's 109 minus 0.43 times your age, and then you get a number. I don't know how well that formula works. You can usually take a blood gas and see what it really is. And see at the mitochondrium, we can come, and if you read the textbooks, to an oxygen pressure anywhere between 1 and 10. So an average of about 5. So we started with 160 and then we end up with 5, and that's called the Oxygen Cascade. So let me go back. Yeah, we start 160-ish, in the windpipe 150, then the alveoli 105, up blood 80 to 97, and eventually that oxygen is pressed through the interstitial fluids, intracellularly, and then from the intracellular plasma into the mitochondrium. Now imagine that we're giving supplementary oxygen, yeah, and then suddenly we're seeing that the fraction of oxygen is no longer 21%, but maybe it can go up to, say, 40. If we have 40, then we need to change this formula to 0.4 times 76, and we see we get an oxygen pressure, which sits around 310. And then we're cascading down to here. We then suddenly see that the arterial oxygen pressure goes up to 180s, and I've seen fraction of inspired as high as 70% run intra-operatively, this meaning if you take your blood gas intra-operatively, you can end up anywhere between 180 or 240 or even higher. All right, so that's the first step. So step 2 is to look at this diagram, graph, whatever you want to call it, and it's called the hemoglobin oxygen disassociation curve. Long word, but what we're really doing is we're looking at the relationship of the arterial blood gas pressure of oxygen. So 0 pressure here, here 80 and 97, and at this other one here, I've looked at the oxygen saturation of hemoglobin, so usually we call that saturation or SATs. Without the SATs of a patient, you will hit that SAT, yeah, we mean that one. And here I've marked 94 and 100%. So normally people are between 94 to 98% saturated, meaning that a fair amount of the hemoglobin has oxygen on it. And remember, that oxygen is sort of like stored in a backup tank. You may call it a tank, but purely that's a backup. It is the blood gas pressure that works through a gradient as the driving force to get oxygen eventually into the cells, into the mitochondrium. So normally our 94 to 98, often we give patients supplementary oxygen. It means that they don't start off with 21% fraction of oxygen, but maybe 30 or even 40 or higher. I've seen even 100% sometimes when we induce patients, particularly on this high flow humidified oxygen machine called OptiFlow. So anyway, what's important to see is this relationship and the curve. So this dotted line is 80 and this dotted line is 97, meaning that's what the normal range of the blood pressure is in your arteries. And if you look 97, we usually should have saturations close to 100%, right? Yep. So if we go to 94%, then see the dotted line corresponds to 80. So this zone is normal, and therefore 94 or higher, usually up to 98, is normal and everything's fine. But as soon as we go underneath 94%, see this huge and fast steep curve coming down. We quickly start to lose our backup tank of oxygen, meaning that our blood actually gets low in oxygen, and that's called hypoxemia, and eventually the tissues and the cells get low in oxygen. That's called hypoxia. So this is one of the standard things we do with patients. We look at the oxygen sats. The other thing, of course, is the blood pressure, which we talk about in another little video. So keep in mind the oxygen cascade, that's the driving force to get oxygen in. Then we have a backup tank with hemoglobin, and the association is such that the normal PaO2 is between 80 and 97, and it corresponds with saturations that are between 94 to 97. Okay, in this session I'm going to talk about blood flow and how it interacts with blood pressure. So what we really want to know is how well is different organs in the entire body being perfused, or perfusion and blood flow are the same concept. Find it very hard to measure. We need Dopplers and the likes, and that's practically not possible. So therefore we look at blood pressures. But a blood pressure reading must translate in an understanding of what kind of blood flow is related to a certain blood pressure. So in the peri-op department, and in critical care areas as well, but particularly intra-operatively and in the recovery room, in the perioperative department, we are concerned about what we call organs of high perfusion. So in general, if I ask any of my colleagues and students, ward nurses, even medical students, what are the 5 most vital organs you can think of, they will mention the brain, the heart, the kidneys, but also the liver and the lungs. So let's just have a closer look at the need of continuous high perfusion and these 5 organs. So the continuous need for perfusion is related to the provision of nutrients for energy production. And if we look at the brain, the heart and the kidneys, they can only metabolize anaerobically, meaning they need oxygen. Without oxygen, these organs start to suffer straight away. These organs are always active, they work all the time, so they need a continuous, consistent supply of oxygen, but also of glucose, which is the substrate that gets oxidized. Then later we get ATP and the like, which are basically chemical forms of energy. If we look at the liver and the lungs, the situation is a bit different. Number one, the liver has a huge reserve capacity. Your body is alive with only 2% liver function left. Also, the liver can rebuild itself over 2 years. And on an everyday moment, the liver also has energy stored in the form of glycogen. And the liver is not always super duper active. You have a heavy meal, then all the nutrients go through the portal vein and reach your liver, and your liver will start working. And maybe you exercise and you have waste products, the liver will start working again. But in between, not very active. So in a surgical setting, when you've not eaten, you're fasted particularly, and then you're anesthetized, the liver is not the most active organ. Now your lungs actually don't perform labor. That's done by the midriff and the intercostal muscles for breathing, and the chest expands and contracts, and basically the lungs follow suit. But they don't put in the hard work. It's done by the muscles, like I said, the midriff and the intercostals. So basically we'll have to look after 3 organs, the brain and the heart and the kidneys. So how do we know what is going on perfusion-wise, blood flow-wise? Well, we need to look at the blood pressure and how blood pressure works. So I've made here a little drawing and an analogy. So I've got a water tank here. So this is a bit like an old Queenslander house. There's a water tank next to the house. It rains, goes in from the roof into the gutter, into the water tank. Then I've attached a pump here, and then a garden irrigation system. So the analogy with the body works that this is your venous blood that is a reserve or a pool, and then it returns to our heart, and then we have an aorta and arteries, and eventually where the sprinklers are, that's where our arterioles are, and these arterioles can vasodilate or vasoconstrict. So why have I used this example? Well, for example, when I was about 4 and I discovered that if you put your thumb over the end of the garden hose, you get a really good jet. Yeah, or if you have a nozzle, if you tighten the nozzle, you get a fantastic spray. But also I realized that the pressure builds up in the hose just before that. So in the body, if we have vasoconstriction of our arterioles, our blood pressure will build up. If we have vasodilation, our blood pressure will go down. So in physiological terms, it's called systemic vascular resistance, or in terms of the man who is all behind the physiology explanation of the blood pressure in heart, Starling, it was called afterload. So the drugs that work on the arteriolar constriction are called vasopressors, and one good example of that is phenylephrine. And in our case study of the obstetric patient, we'll see that obstetric patients will get the vasopressor intra-operatively, and it is phenylephrine. So let's go back here to our pump, and there I have CO, that's cardiac output. And cardiac output is simply how much blood is pumped out by the left ventricle over a minute of time. So the equation is very simple. We have a heart rate, and we have what is called a stroke volume. So stroke volume is with each stroke of the heart, with each pumping action of the heart, how much blood is actually being pushed into the aorta. So on general, the ventricle fills with about 140 mils of blood, and then it pumps out about 70 mils. So cardiac output regularly at rest would be 70 times 70, which is about 4,900 mils, so say 5 liters of blood. And the average person also, adult person also has 5 liters of blood. So really your heart at rest pumps out your entire volume of blood around your body in 1 minute. So the strength of the pump, or the strength of the heart, Starling called contractility. So now we've seen 2 factors according to Starling affecting stroke volume. The strength of the heart, and the stroke volume is also determined about what kind of resistance it needs to pump against, and that is called the afterload. Understanding that the afterload cranks up the blood pressure, and it becomes harder for the heart to pump blood out into the system. So therefore, sometimes when the blood pressure is too high, we need to start supporting the strength of the heart, and the drugs that do that are called inotropes or inotropes. Either, potato, tomato. So I call them inotropes, but a lot of you would call them inotropes. And there is positive and negative ones, positive making the heart stronger, negative ones making the heart weaker. In general, when we say inotropes or inotropes, we're thinking of positive inotropes, increasing the contractility. And so the last point here, where I had my water tank and my venous blood pool, that factor is called preload by Starling. So your preload you can compare a little bit with an elastic band. So if you stretch an elastic band, you get a good rebound effect. If you don't put much stretch on an elastic band, then you get hardly any reflex. And if you overstretch an elastic band, nothing will happen. So Starling said the amount of blood, the volume of blood that's loaded into the ventricle, we call it preload. It will stretch the myocardial fibers just like an elastic band would be stretched. And the more stretch, because of more preloading, the more or higher you have the stroke volume will increase. But if we stick with our analogy with the elastic band, there comes a point that we overstretch it, and that's called decompensation of the heart, and the stroke volume no longer increases and eventually will decrease. So how do we work on the preload? Well, we either can raise the legs, and that theory says, the textbook says, there's about 400 mils of blood pooled in your legs. So if you raise them, you add 400 mils to your venous blood pool, and you will increase your stroke volume, and your blood pressure should by rights go up. Or you can give IV fluids, a bolus of 250 mils, for example, or maintenance fluids as well. And so we then need to look at what is called fluid responsiveness. If we were to raise legs and give IV fluids to increase preloads, to raise our stroke volume, therefore cardiac output, and therefore blood pressure, we need to see if that actually will have an effect, right? So if you look at this curve here, that's the famous Starling curve. So at the bottom we see that we can increase preload, and at the vertical axis we can see the stroke volume variation. Delta SV means stroke volume variation. So you can see here that if there's not much water in the tank, and then we start adding by raising the legs and by giving IV fluids, our stroke volume will start to become bigger and bigger and bigger. But there comes a point here where we go over the hill, and more preloading actually becomes overloading, and we're sloping down. Okay, so in the IV fluid balance section we go into IV fluids a little bit more, but it's a good thing to note that if you give 1 liter of Hartmann's or Plasma-Lyte, that within half an hour only 80 to 200 mils will have stayed in your circulation, and the other 800 to 920 mils will actually go into the interstitial fluid, and to a little degree in the intercellular fluid. So you cannot just keep loading and loading and loading fluids in your venous system and expecting it to stay in your circulation. You actually start creating edema, which is not a good thing. That's why sometimes we need to tune the blood pressure up with vasopressors. And the example again was phenylephrine that we'll use in our case study. So back to our original question. Now we know a bit more about blood pressure and how to control it. What does it actually do for blood flow? And so this is explained here in this little diagram. So we see blood flow against MAP. That stands for mean arterial pressure. So often it's called the mean. And what is the MAP? Well, you just apply a little formula to your blood pressure reading, and then you get a MAP. So what's the formula? It's the easiest one is to take 1 times the systole, you double the diastole, add them together and divide it by 3. So you would get, say, 120 over 80, 120, you double 80 is 160, 120 and 160 is 280, divide by 3, you get a mean of about 93. And if you look at this diagram, you see no pressure, no flow, and then as your mean starts cranking up, your blood flow becomes more and more and more. But here, around a mean of 60, and different textbooks will give you a different number, and particularly different number for organs, but let's just stick with 60. And then you see your blood flow remains the same as the mean is cranking up. And it's only if you reach really high means, around 160, 180, suddenly your blood flow goes up again. So that means that in the organs of high perfusion, brain, heart and kidneys, we know that the blood flow is steady even if the blood pressure fluctuates, but we just want to make sure that the mean is adequate. So it could be a mean of maybe 65 or higher, 70 or higher, but intraoperatively, if you have a mean of 80 and higher, you start sort of to relax because you feel that the brain, heart and kidneys have adequate blood flow. So this one, and knowing the 3 organs that we're worried about clearly describes the relationship of proper blood flow in relation to blood pressure. And we know the 2 things we do to maintain blood pressure will be IV fluids and query vasopressors. So we talked about oxygen, and we talked about blood flow, and our other important ingredient to keep the energy in our vital organs happy is glucose. So I'm looking here at the word stress, because three main factors that cause stress to a patient will be anxiety about the procedure, and therefore we as nurses try to alleviate the anxiety in people by having certain strategies in place, particular distraction, lighten the situation up for people. If they're still really stressed, a doctor can give some midazolam, which is an anxiolytic. So that's important to relax the patient up. Then the surgery will cause stress. It causes injury. The body itself responds to surgery as it is an injury, and it will cause a stress response. And then of course there is the fasting. So some people have stopped eating a day before, the night before, say 7 or 8 o'clock, before the day of surgery, and then come to the hospital at 7, and surgery doesn't start till maybe midday or later, and so you get symptoms of starvation. So when we are in stress, we have an acute response, and acutely our blood glucose goes up, but that causes a rebound effect because insulin goes up, and eventually blood glucose goes down. The chronic response means that corticosteroids are released, like cortisone, from the adrenal cortex, and they cause a resistance against insulin in the body, and that means that insulin is no longer as effective and blood glucose will go up. So what will the overall result be? We don't know. So if we are worried about patients with diabetes, for example, we follow the recommendations of the Australian Diabetic Society when taking blood sugars every hour. But also if we do a blood gas, we can see what the blood glucose levels are. What's been found was, in optimizing a patient, that relating to the fasting, we can reduce the stress by giving 100 grams of sugar, like in a sugary drink, apple juice or some type of sweet juice, the night before, and then 50 grams 2 hours before surgery. And that's because fruit juice is a clear fluid, and that's perfectly allowed to be consumed up to 2 hours before the surgery. So, finishing off our little section on oxygen and glucose and blood flow. So, how do we know there's a good blood flow, particular to our organs of high perfusion, brain, heart and kidneys? We can look at the mean, and we can strive for a mean of 80, and we're happy. So because people have fasted, we need to preload with IV fluids, and we can look into if we have to give a vasopressor if the admission of IV fluids is not enough. Keeping in mind that anesthetic drugs are vasodilators, so reduce the afterload and therefore lowering the blood pressure as well. So secondly, oxygen and glucose. Well, we have a pulse oximeter on, but that only measures the hemoglobin oxygen saturation. So we know we want the saturations to be 94 or higher, maybe 95 or higher. Intra-operatively, we're giving high fractions of oxygen. The World Health Organization advises up to 80% fractions. So what that means usually is that if you use those high fractions intra-operatively, the arterial blood gas will be really high, higher than the normal range even. Normal range was 80 to 97, but intraoperatively it usually goes up to 180 to 240 even. But we can take an arterial blood gas which will provide us with information of what it really is like, that PaO2, and a blood gas also measured the blood glucose levels. So the blood gases look at other things as well, but you can see double whammy there for us, because we can really see how much oxygen and glucose is going around for that patient. So, intra-operatively specifically, not in the recovery room, we apply a 3-lead ECG and we can monitor ST segment changes. So, elevation usually means it means like an infarction, and depression means ischemia. But of course, you also have non-STEMIs and non-angina pectoris. Basically, ischemia without ECG changes. There's a special device we use called INVOS, and that's not routinely used, but that measures cerebral perfusion. So any indication that the circulation towards the brain could be impaired and not adequate, we can use the INVOS. And then of course we can do hourlies, hourly urine input. My formula that I learned was 0.5 mils per kilogram per hour. And then we can do blood tests and look at the wastes that the kidney should excrete. And we're looking at serum creatinine, or creatinine, some people say, the creatinine or creatinine clearance, and also blood urea nitrogen.